this week on the BackTable podcast.
You know what's interesting is before, I think we used to have this kind of theory that kyphos will cause like adjacent level fractures. And to be quite frank, I also would kind of counsel patients on that, and I would think that as well. There was a good study that I think they did a meta-analysis of almost like 3,000 patients. It was like 2,800 and change. And basically, long story short, their conclusion was that it wasn't actually the kyphos that were causing the fractures, and it was actually just kind of the fact that people are osteoporotic or on steroids or whatever their risk factors are to begin with. Whether they get a kypho or not, they're going to get more fractures.
This is the BackTable podcast. This is part 2 of a series on difficult spinal ablation and kyphoplasties. I'm joined by my friend, Dr. Asad Baig from Columbia University. Asad's going to share a couple cases with us. How's it going, man?
Good, man. Good. Thank you for having me on. I appreciate it. I'm, excited to share some of these cases, and I'm hoping that, we can. So I picked a couple of cases that were kind of unique, a little bit kind of outside the box a little bit. There'll be components of kind of run-of-the-mill kyphoplasty, but these were kind of unique, so I wanted to kind of show these.
All right, right on. Let's kick it off.
Yeah, so this was an 83-year-old female with osteoporosis. You can see that, spinal hardware in the past, and she's had previous kyphos. This was all done kind of at an outside institution. Had hyperkyphosis and in a pretty substantial amount of pain, about 7 out of 10. I personally like getting the ODI and the RMDQ. For those who may not be familiar with it, that's the Oswestry Disability Index, and that's the Roland-Morris Disability Questionnaire. Basically, it's kind of like it's a questionnaire that helps you determine how functional or not functional someone is, or how kind of mild, moderate, or severe kind of the debilitating nature of their kind of spine diseases. So that's helpful. What I do is I like to get it kind of pre and post.
So do you get this anyway, or do you get this specifically in the setting of osteoporotic compression fractures?
I do it with all of my patients, whether it's kind of pathologic or kind of osteoporotic. One of the things that I like, seeing, and I'll probably kind of put out something, about this, is seeing pre and post kypho or pre and post kind of osteocool, or, what's kind of the pain score kind of difference, and then what's also kind of these functionality scores and kind of these disability kind of indexes. How did they improve, pre to post? Like, how much did they improve by? One of the other challenges is, when patients, because pain is pretty subjective, right? Like for some people, like, you get a mosquito bite and it's like a 10 out of 10. And then some people will get, like crushed by a truck and be like, oh, like, I'm all right. It's like 4 out of 10. It's funny. We had this experience with my wife. She's like, when she gave birth, she was like screaming. She's like, oh, it's not so bad. I feel like I'm at like a 4 out of 10. I'm like, I think you're a little bit more than I appreciate how strong you are, but but I say this to say that everyone's kind of, pain level is subjective. This, I don't want to say it's totally objective because it's still based on kind of what the patient's answering, but I think it's a little bit more of an objective measure of kind of how the patient is doing in terms of daily activities and things like that.
Well, so it's got to be a challenge in one like this. She's 83. She's got a lot of hardware. She's had numerous fractures in the past. How did you even identify if there's a fracture in this patient? She's probably hurting all the time.
Yeah. So this was really challenging. And this was where, I'll show the MRI actually. The MRI was really not that helpful actually, because there's so much hardware. But what was actually super helpful, I'm not going to say it wasn't helpful at all, because it did identify the acute to subacute T7 fracture. The other thing that was interesting about this case was that, you could see it a little bit better on CT, but if you look at T10, that's kind of the top of like the spinal construct. One side of it does have cement, and, it appears that it is within the vertebral body, but another side of it, you could see in like that third image, the screw has actually migrated into the disc space, and it's actually almost causing the compression. And if you look at kind of the that that third image, you can see it kind of a little bit more clear on that. And below it, like that's kind of where the fracture is. And she was feeling pain kind of in this region. You feel the hardware. And like, you know, generally when I do a physical exam, I always tell patients, like, I know it's not hurting in your neck, but you know, I'm going to start from your neck and I want to work my way down. And she was really hurting kind of right at the top of the spinal construct. Anyway, so because she's got this kind of these transpedicular screws, it's going to make this case like really challenging. And I was pretty honest with the patient. I was like, look, there may be a small window where I can kind of get the needle in, but there is a chance that if the pedicular screws are like kind of totally in there, I may not be able to safely get in. There are alternative kind of ways of approaching it, but I told her kind of the safest way that I try kind of doing these kyphos with is always going transpedicular. You can go extrapedicular as well, and there are other approaches too, kind of a bit more of kind of advanced techniques where you can kind of go inferiorly. You know, you just have to be careful there with the foramen. But anyway, getting back to this case. So what I ended up doing was the right side was the side that actually looked okay. It didn't look like the screws had migrated. There was adequate cement around the transpedicular screw. But it was the left side where, and this was also, I didn't show the axials, but that's also important to kind of look at the axials too, to look at the pedicle and see if there's a slice or two where maybe the transpedicular screw is not totally in the pedicle, and you can actually kind of get in that way. Alternatively, could I have gone extrapedicular? Possibly. You know, that's another kind of option where you kind of just go around it. Either way, kind of I approached it, kind of went into the lateral aspect of the pedicle, kind of got in. Initially, I got in, if you look at the images, I got in like a typical kind of bipedicular kypho where you're kind of landing the tip of your drill or kind of the inner aspect of kind of the inner stylet close to the spinous process, but staying on your side. Realizing that this was not your typical kypho, what I ended up doing was, you know, after checking the lateral, and you can see that in the second image, I wasn't all the way kind of anterior. So I pulled back a little bit and I kind of did like a hard, like kind of medialization. And this is where kind of like, you know, the tools that, you know, Medtronic has in terms of like the bevel, it's really useful because it's directional and it allows you to go in a certain direction.
I use the bevel on almost every case, even the easy ones.
Yeah, exactly. It makes it so much easier. Some people even dock in with the bevel. I tend to, if it's really osteoporotic, like I can just go with like the purple, kind of like the diamond tip or whatever. But the bevel I think it's a great tool. And that's what I used here basically to actually kind of get across. And so if you look at this image right here, right? So I take it, you know, in the AP kind of similar to where you would want to land it for a normal kypho, but seeing as I'm probably not going to be able to get anything here because it's totally cemented. So I said, all right, let me pull back, right? I still have some space on the anterior aspect. So I kind of brought it a little bit more like almost like a unipedicular where I'm coming across to the other side. Brought it all the way anterior like we typically do. And here's a tool that I use, which, to be very honest, I was really resistant initially to using this tool, but my local rep, he's a good guy, Mike Muldowney, he would always be like, yeah, like, you know, Dr. Baig, like, you know, you want to try the curette? You want to try the curette? And a lot of times I'd be like, no. And then one time I tried it and I was like, shoot, this thing actually kind of helps. I don't know if, Mike, have you used the curette at all?
I actually used when I was in Nashville. I used it all the time. I haven't used it in a few years, but I used to use it in probably a half to 2/3 of my cases.
I think it's a little underrated, you know, because like everybody knows about the balloons, but I think the curette gives you a little bit of that extra kind of spacing and everything if you need to clear a little bit of space.
Yeah.
So use a curette, kind of got my cannula kind of in position, got the cement device in position, and then started cementing, and it kind of filled in really nicely. It started out kind of on the right side and came across laterally, which was super nice. And it kind of coated the superior cleft as well, which I was really happy about. These images right here are from T7, which was just a regular old kypho. So I think that I just wanted to show this case to show, you know, I think they called it like a rescue case or whatever, but just to show that like sometimes these things do happen. And if a patient is feeling pain there, like, even though it is a little challenging, it's something that can definitely be done.
It's probably very important for this patient who is, my guess is probably a challenge to redo the pedicle screws. May not even be a candidate.
Exactly. Because nowadays, a lot of the ortho spine and neurosurgeons, they'll just cement their particular screws in with the idea that they're not really planning on taking them out, which is great for the patient because then hopefully you can avoid like revisions or anything like that. But it kind of makes it tough for us. So on the post, these images right here are kind of the post. I was pretty happy with that, and patient did well overall. One thing that I do is I try to see patients kind of 2 to 3 weeks after. I think she was going away or something. I don't remember exactly, but for whatever reason, she followed up 4 weeks after. She was doing a lot better. She was able to kind of ambulate with a walker now. Before she really couldn't walk very much. And she still had a little bit of residual pain, which, one thing that I always tell my patients is, what are the expectations, right, of a kypho or of an osteocool? And I try to always be a little bit cautious, and I'm always like, look, it's probably going to get you about a 50% improvement in pain and a 50% improvement in functionality, with the caveat that, like, some people do better, and in rare cases, like, some people don't get to exactly 50%. And a lot of our data shows kind of this, the same thing, that you get reduction from 6 or 7 out of 10 to 2 or 3 out of 10. The functionality scores improved too, the ODI and the RMDQ. So she was pretty happy about that. Mike, we do so many things in IR where it's like really tough because people are really sick, and like, whether it's end of life or, they have an abscess or whatever, that kind of stuff. But this is one of those things where, with an ablation, with a kypho, you can actually kind of, you see improvement, and you're really getting people kind of back to their lives. So overall, patient did pretty well, was able to get back to her normal activities of daily living. One of the things that I always do for my patients is I always want them, and I'm sure you probably do the same, Mike, send them to PT.
Yes.
It's like, and I always tell them, like, I can fix the fracture, but a lot of the homework afterwards, like, I need you to like meet me halfway, And in terms of flexibility and strengthening of kind of like paraspinal muscles and just overall kind of strengthening of the muscles definitely helps with kind of improving, kind of the force of where things are going, right? Like, if you have strong muscles, it's going to be able to take a little bit of the force off of kind of the bones. And endocrinology is like huge. It could take a little while to get into endocrinology, but I think that it's super important in terms of overall bone health and kind of getting them DEXA scan and T-score and making sure that they're adequately followed up with that.
100% agree.
I just showed a crazy case where it was kind of a rescue case, transpedicular screws already in place. You kind of have to figure out the angles. This is somewhat similar, somewhat different. This is a patient who had a fall, and the fall occurred about a month and a half prior to the consult with me. I always see my patients in consult before doing the kyphoplasty, whether that's in clinic or whether that's kind of inpatient. I think it's really, really important to just see them.
Good. I'm glad you said that. Seeing them in a consult before, because sometimes, we'll get these as outpatients, and a lot of them will come, from outpatient imaging. Somebody fell or somebody sneezed, something like that. And, they'll get their MRI, their CT, and they've got what's very clearly an acute compression fracture. And that is something that I have gone back and forth with how to manage, and in some places, they just order the procedure and they show up and have it done. But, I like to have some communication with these people beforehand, but I don't always insist that they come and see me in clinic. This is where sometimes I will do like a video visit and then examine them beforehand. But it's a challenge because, you want to do this the right way, but you also want to get them treated as quickly as possible. And I'm curious how you manage this.
Oh, yeah. Yeah, absolutely. I mean, pre-COVID, we were always seeing patients like in clinic, like all the time, like physically. And I think what COVID did is it kind of changed the game a little bit, right? It probably took what was going to happen anyway, like in a few years, and kind of just, it was a catalyst to kind of speed up that process, I think.
Sure.
we see a lot of patients now virtually. There are some patients who cannot like make it. They may be, I've had patients who are a couple of hours away.
Same.
And they're in pain and they want to see me. And it's one of those things where I do tell them that, look, I'm going to see you as a video visit, but I do have to examine you at some point, whether that means you coming in or that means before the procedure. I'm going to examine you and make sure that you actually have pain where your fractures are, right? Because if your pain isn't where your fractures are, then there's a chance
that help you.
Yeah, exactly. Then it's not really, like I always say, we treat the patient, not the image, right? So if you're not having pain there, then we may have to have a discussion on the day of the procedure that maybe we don't need to do this. I think that as long as patients kind of hear that, they're like, okay, that's reasonable, that makes sense. So that's something that I do try to push for them to come in person. But I mean, look, we live in reality, right? The real world is that not everybody's going to be able to come in, whether that's due to logistics or whether that's due to pain. And you just kind of have to figure out a way to still adequately assess them. And that's kind of also where the ODI and the RMDQ and like these different kind of questionnaires can come in as well. Because there's no substitute for a physical exam. Don't get me wrong. But these are kind of clues that can clue you into whether it's like really severe or this is kind of just a minor inconvenience that patients are just kind of like able to deal with. Anyway, so this is a patient here, and I wanted to show this to kind of impress upon us how important it is to treat these pretty quickly and to follow these up if you're not going to treat them right away. So this x-ray was taken, the time difference between this x-ray and this CT was less than 2 months, right? So if we're looking at kind of, these are sagittal views, right? This x-ray, this is L5, L4, 3, 2, 1, T12, right? So correlating with L5, L4, 3, 2, 1, T12, right? So this is T12 on the CT literally less than 2 months later, and 5, 4, 3, 2, 1, 12. This is T12 prior. So it really went from something that was like a pretty easy, straightforward case to now we've got almost like plana, right? Almost vertebra plana. And I spoke with the patient, and the poor patient had been in pain for about 2 months. And, I told her that, look, I wish I had met you 2 months prior. We probably could have taken care of this and spared you a lot of pain and height loss and all that stuff. I told her that, I'm still going to try. I think we can do it, but it's definitely a little bit more challenging. And if it gets dicey, I may not do it. So I laid out all the expectations, right? With the understanding that if it's something that we can do safely, I'm happy to do it. I'm happy to help. But this was kind of the situation.
You had mentioned the weight loss. Go through that again.
Oh, yeah, absolutely. So the other thing that she had mentioned was that she had maybe about a 30-pound weight loss over the course of about 2 to 3 months. And it was not purposeful, and it was kind of paired with appetite changes. She was very much like, I don't feel like eating. I just have low energy. So obviously when you hear these things, kind of the bells go off in your head like, oh, shoot, are we dealing with kind of a cancer situation here? And I bring this up because, we're kind of talking about, OsteoCool and kind of when to use it. We know that it's on label for kind of metastatic disease. The question becomes, though, like when you have these kind of unexplained, weight loss and kind of cancer-like symptoms, do you just ablate or not? And, I think it's a good discussion to have. And I don't think there's a one-size-fits-all thing, but I think you have to at least consider it.
Sure.
All right, awesome. So initially, I ended up doing T10, T12, and L2. And these are the images. I had started with T10. One can make the argument, do you want to do the hardest one first, or do you want to do the hardest one last? I tend to get the easy ones, quote unquote, easy ones out of the way first. This way I don't have any other cannulas in there and I can kind of just focus on that. So that's what I did. The first image right here, kind of getting the drill all the way through. We've got our balloons and everything, kind of typical kypho, and kind of cement look great and everything. So this right here is, I don't know if you can see it all that well because the image is a little small, but the drill, like the height of the vertebral body is basically the size of the drill.
Let me ask you something. I'm looking at the angles that you have, and you have like a really nearly horizontal angle in the AP plane. When you're getting these lined up, are you taking the needle down, on a straight AP orientation, or are you angling this a little bit to open up the pedicle?
So I do a little bit of both. Like
Okay.
most of the time, I like to initially line it up in AP to see if I can see, because to me, it's like, all right, you got the spinous process in the middle. You've got your, kind of nice oval pedicles kind of in the superior, half or 2/3 of the, superior 1/3 of the vertebral body. I like that image. But I'm not gonna lie, there have been times where it's a little tough to see and I got to go to like the oblique or the Scotty dog. And with those, I'll kind of just go right down the barrel. So I think, and there are certain times where I'll kind of just dock in Scotty, like, in the oblique, just to make sure that I'm at the lateral aspect of the pedicle. And then once I'm in and like I'm in bone, then I'll go back to AP and then kind of make sure that I have a little bit of daylight, kind of between the cannula and the
medial margin.
Exactly, medial osteopedicle. Yeah. So yeah, this was definitely one of those where I had to just be really careful. It was kind of nice. It went all the way kind of forward. I was actually thinking initially like maybe I should just do this as kind of a unipedicular, but this is one of those like how on Twitter like people post like their full fills. This was a little bit like that where I was like, man, this looks really good, but man, I wish I could just get a little bit of cement in that kind of lateral aspect on the right side. So this is crazy, but I actually, just to try to help this patient out, get as much fill as possible, I accessed the right pedicle as well, which was a little bit more difficult and ended up getting what looked like this. So was pretty happy at the end. And most importantly, right, like I know, and this is something that I always tell like the residents and fellows, like we as radiologists, as human beings, like we want to see the visual, right? But a lot of times, like it doesn't need to be picture perfect to help the patient. And I think that's something that we just have to remind ourselves all the time, that it's not as much about the image as it is kind of about kind of the clinical status of the patient. So anyway, I saw the patient in clinic about 3 weeks kind of post. And, by the way, sorry, one thing I did not mention, going back to osteocool, I did actually biopsy and osteocool at this point, because at this point she had no biopsies done. She hadn't been worked up for anything at all. And it's funny, I was just speaking to my colleague today, one of my colleagues, who basically said that, he biopsies every single kypho because they're...
Interesting.
Yeah. I don't biopsy every single kypho, but I'm starting to think that it's not a bad idea. One of the points that he had mentioned is that there it's a small percentage, but there is a percentage of people that, we may think are just osteoporotic, regular, trauma compression fractures, but they actually have some underlying disease that is just not picked up until we do the biopsy. And a lot of these patients, like for example, like this patient and like, the other patient, and I have others too that are like this, where they may not have too many kind of health issues or anything like that. And they're not really seeing doctors that regularly. So they're not really checking in like, oh, is my weight really fluctuating that much or whatever? Or they may not know. They may not know, that like, hey, if my weight drops a lot, like, I should tell my doctor. Some of my patients are like, doc, I can't explain it, but I lost so much weight. Like, I'm so happy. I'm like, yes, I'm happy for you, but, we probably need to explore this a little further, Yeah. All right. So this is kind of what it looked like. She did a lot better, but she was still having pain. After I saw her, I said, all right, you know what? Let's get an MRI. Let's see what else you got going on. And then let's do another clinic visit. And if you're still having pain kind of, at those sites, then we can go ahead and treat it. I did follow up though in about 2 to 3 weeks after. So I think one of the things that I definitely want to impart is if you're not going to do the kypho or the osteocool, one thing that I would say is definitely follow up with the patient in a couple of weeks and just make sure that like clinically things haven't gotten dramatically worse or things haven't changed. At this point, when I had seen her, the biopsy had come back as negative, so I did not osteocool the rest of it. And by the way, since we're speaking about osteocool, one thing I would say is that when you're doing it, there's the color coded system on the drill where it's like the yellow, the blue, the orange, and the green. So that kind of correlates to the size probe basically that you're going to use: the 7mm, 10mm, 15, and 20. I only say this. I know most of the audience is going to know this, but I recently, actually, I was just teaching a course on this, and there was a fellow that had just graduated, and there was a resident who had heard another BackTable talk that I had done and that we had done together. Because you never know what the reach is, right? Like, I know you guys have great reach, but like, this was kind of cool to be like, they're like, oh yeah, I heard on BackTable. So this is to to the fellows and the residents who are listening. That drill is going to kind of help you out and tell you which kind of ablation probe to use. Okay. The rest of this case was kind of just a regular kypho. You can see where the balloons are kind of filled in pretty nicely with cement. At the end, obviously, a lot of levels have been done. And by the way, this is an image that I see a lot in my lung transplant patients, because they're on steroids, and unfortunately, I mean, you know how it is with steroids. It's like, it's just a matter of time, right? There's going to be fractures. And so there's one patient where I ended up doing, this was over the course of like, 3 or 4 kyphos. I ended up doing like T5 to like down to L5. She did great. I mean, I called her the other day, and she was like on the playground with her kids after being in the hospital for forever.
It's almost like once you get started with those, it's like, should we just do them all? It's like treating, post-fusion patients for prevention of proximal junctional kyphosis. We used to do that in Nashville. Anytime they get fused, we just treat the level above. You almost want to do that from the beginning before they get bad fractures.
Yeah. That's, I mean, there's definitely some people that will do that.
Interesting.
And what's interesting is before, I think we used to have this kind of theory that kyphos will cause like adjacent level fractures. And to be quite frank, I also would kind of counsel patients on that, and I would think that as well. There was a good study that I think they did a meta-analysis of almost like 3,000 patients. It was like 2,800 and change. And basically, long story short, their conclusion was that it wasn't actually the kyphos that were causing the fractures, and it was actually just kind of the fact that people are osteoporotic or on steroids or whatever their risk factors are to begin with. Whether they get a kypho or not, they're going to get more fractures. That was something that I just discussed with endocrinologists as well, actually, I think last week or so. So, in summary, this patient ended up doing really well, ended up going back to work. She was out of work for a bit. She did a job where she had to be standing for a while. She did follow up with physical therapy and endocrinology. And the last I saw her, she was doing really well. She said every once in a while she felt a little dull ache, but nothing like kind of what it was before. And she was super thrilled.
That's awesome.
I don't know, Mike, you have any comments, concerns, questions?
I'm with you. I mean, the dull ache brings up an important point. So, like you said, counseling patients, setting expectations is one of the most important parts about it. That's actually to me, like one of the key things about seeing these patients beforehand, rather than just having them on the table, is you want them to know what to expect. And what I tell them is some people are going to get completely better and their pain is going to go away. Some people are not going to get better at all. And most people are going to fall somewhere in the middle. And I usually tell them, I expect most of the time, like that sharp, really bad pain is going to get better, but you're still probably going to have dull, aching pain like that. And that's going to take a while to go away.
Yeah, exactly. And I always kind of joke with patients, and I'm like, look, I don't have some magical powers. I'm not gonna make your pain go to totally away. I mean, for some patients it does, but So yeah, man, these were kind of good cases, and I think one of the things that I definitely want to impress upon people in terms of osteocool, I'm a big proponent of it. I think that the on-label kind of taking care of the tumor is really important. But, we had another episode where we talked about the basivertebral nerve. That was, obviously FDA approved for the lumbar spine, but every vertebral body has nerves and has a basivertebral nerve root. So you have to consider it. Now, I'm not saying we do this for this reason, but you have to consider when you're burning, you're probably taking out some of those nerves as well and the nerve root as well.
All right, man. Well, thank you for sharing your time and your expertise.
Yeah. No, thanks for having me.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @BackTable MSK on Instagram, X, or LinkedIn. BackTable MSK is hosted by Jacob Fleming,
Michael Barrazza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.